I'm quite passionate about this topic, okay? And yeah, I learned this model, and it's called the fear avoidance model. And we were taught it in university, and as soon as I got to work, I was instantly in love with the model because it explains a lot. Okay, so this is where patients are. Patients come in and they have sciatica, for instance. Okay, so they start right here. There's one or two pathways that the patient is going to go. Okay, they're either going to go to the right side here, or they're going to go left. This is the positive side. This is the negative side. So when someone experiences sciatica, they have the pain experience. If they start to deviate to the right side, the first thing they'll come across is pain catastrophizing. So this is what we've already spoken about. Okay, this is when patients go, oh my God, if I move, I'm going to cause my back to get a lot worse. I'm going to cause damage. And all these thoughts and feelings will then convert into an emotion. The emotion is to catastrophize about it. So kind of disable ourselves. Okay. And then if we read things like threatening illness information, Dr. Google, that's, and unless you're a medical professional, you really shouldn't be reading too much into Google, because that's all Google's going to tell you is going to see a doctor regardless. There is some good information, but there might be some threatening information that we may come across when we think, oh my God, this is going to make it a lot worse. And then that's when we start to hit this cycle, and that's where the issues start to occur. So as we move up to the scale, we've got the pain-related fear. We literally become fearful of movement, and it's real. I've seen it tremendously in clinic. I've had some patients who have been shaking and their hands have been like this because they've been so anxious about what is going on in their body. You don't know what's going on. This is why the process is so important with a trained professional, because we are trained to get rid of related fear. We are trained to kind of educate the patient as to why they're experiencing their symptoms, how this has likely come across, and most importantly, what we can do together to get it resolved. So as we move up again to the scale, we start to get avoidance and hypervigilance. This is one of the most significant factors on this chart that I see a lot. I have patients, so I had a sciatica patient a month ago, and he loves running. He's really passionate about running. But then he stopped, because he genuinely thought, he became so hyper vigilant about it. He thought to himself that if he continued to run, he was going to cause damage. And he literally psychologically blocked himself from doing something that he really enjoyed, something that's good for his mental health and his physical health. And then this is when we reach the end of the scale. So we start to use disuse, depression, and disability. This is when people really tend to stop. And then the damage just gets, they're putting themselves at risk of further damage because their muscles are getting tight, their body's not being used properly enough. There may be compensation patterns going in, and then this then feeds back. It's a feedback loop, and we call this the negative feedback loop. And that's where most patients typically find themselves with chronic lower back pain, especially sciatica. So someone may have sciatica for the first time, and then they go, oh, okay, this is quite painful. I'm starting to get all these weird symptoms, especially like pins and needles and numbness. That doesn't feel like my normal leg. And then they start to go, oh my God, what happens if I've damaged my nerves? What happens if I damage my nerves? So then they go on to Dr. Google. And then Google goes, oh, there might be a tumor there. It most likely isn't, but this is what people read. And then they go, oh my God, now I've become fearful of this issue. What if it is something really bad that I don't know about that might stop me from working, might stop me from earning money, might stop me from doing the things that I genuinely love doing, might stop me from exercising, might stop me, waking up in the morning. I might be a bit angry with my wife or my husband because I'm in a lot of pain and discomfort. And then you start to get avoidance and hypervigilance. Oh, I can't do this. So you recognize that language. Oh, I can't do that because my back. Or I can't go for the bike ride today, or I can't take my toddler for a walk, or I'm sorry, I can't play with you on the floor. We hear these languages all the time within the clinic. And then that's when it hits disability. That's when the patient's mental health really starts to become affected. And this is our main priority. All of our patients will progress into this. And then this is our job. This is what we are trained to do, is to educate patients to to get out of this negative feedback loop, and we transition them into the other course, which is no fear. Once you have become educated about why you're experiencing the symptoms, how it's happened, the fear starts to take away, because you think, oh my God, I've actually got someone here who knows what they're doing, who's got clinical experience in this issue, and most importantly, has helped hundreds of other people just like you, to get them out of that issue. And then as we start, then they start to confront it. This is treatment. That's when people start to move more, or they start to exercise, or they get a professional opinion like manual therapy or physiotherapy or any sort of alternative modality that to help them go out of pain. And then that is where they finally recover. And all patients will experience this. And I believe that is the single most significant factor as to why any patient with shoulder pain, headaches, neck pain, mid-back, tight stomach muscles, it doesn't matter. This is why they come into the clinic, because they are in that fear state. And there's a lot of apprehension. There's a lot of the unknown. And as creatures, we don't like the unknown. We're really not that into it. And then that is when they want our opinion, because we need to transition that patient from a state of fear to a state of confidence. As soon as that patient has clicked and they've got that confidence, that is when they start healing, and then that is when they start getting the results that they want.